Good morning, everyone. I would like to share some insights into my PhD thesis titled Optimizing Techniques and Outcomes in Implant-Based Breast Reconstruction. Allow me to introduce myself. My name is Dóra Fedorcsák. I'm a fifth-year medical student and a first-year MD PhD student. My supervisors are Zoltán Klárik and Lőrinc Frivalszky. My vision is to provide the best possible surgical care to breast cancer patients, and my mission is to determine which adjunctive materials can help achieve a better surgical and aesthetic outcome. During the past 3 months, we have started working on 3 projects, 2 projects, both started in this fall. The first project is titled Investigating the Effect of Adjunctive Materials on Implant-Based Breast Reconstruction Outcomes in Irradiated Patients. In 2022, 2.3 million patients were affected by breast cancer worldwide. 20% of these patients undergo breast reconstruction after their mastectomies. As you can see from this graph here, more than half of these are implant-based reconstructions. Half of all breast cancer patients receive radiotherapy at some point during their treatment. Radiotherapy causes tissue fibrosis, therefore leading to risk of capsular contracture, implant loss, and infection. These complications can result in reconstruction failure, which can be up to as high as 40% in irradiated patients, compared to only 8% in non-irradiated patients. The use of adjunctive materials can help surgeons achieve a better surgical outcome and less complications. These adjunctive materials can be biologic or synthetic. Synthetic materials can be resorptive or non-resorptive, and biologic materials are cellular dermal matrices. Our aim is to determine which material is most useful in patients who received radiotherapy. Our clinical question is, which is the safest and most satisfactory method in implant-based breast reconstruction? Our PICO consists of a population of patients who underwent both implant reconstruction and radiotherapy. We're comparing biologic to synthetic meshes, and we're looking at surgical outcomes such as skin necrosis, capsular contracture, infection, implant loss. We also would like to investigate patient satisfaction and cosmetic outcomes. We hypothesize that the use of adjunctive materials in breast reconstruction can help achieve a better surgical outcome and quality of life. The clinical implication would be implementing the use of these biological or synthetic meshes to achieve a better quality of life and cosmetic outcome. We have conducted a search in 3 databases, with the search key consisting of 2 domains, the first domain focusing on implant-based breast reconstruction, and the second domain focusing on these biologic or synthetic matrices. Our key articles all view similar surgical outcomes and have a follow-up of at least 1 year. During the article selection, we have started off with more than 12,000 articles, and after duplicate removal, we have arrived at more than 9,000. And with my selection per Levente Dolavicényi, after title and abstract selection, we are now at 112 articles. The topic was declared feasible. We have registered it on Prospero. And after title and abstract selection, we are now moving on to full text selection and data extraction. Our second project is investigating the efficacy and safety of negative pressure wound therapy in prosthetic breast reconstruction. In 2022, 150,000 reconstructive procedures were performed in the US, and 80% of them were implant-based. Infection rates of these procedures can range from 2.5 to almost 25%. These complications can lead to implant removal, delays in administering oncological therapy, such as radiation and chemotherapy, and also increased healthcare costs. Negative pressure wound therapy can assist in the reduction of edema, can provide increased donor perfusion and granulation tissue formation, and most of all, in reducing bacterial colonization. Negative pressure wound therapy consists of the vacuum device, a suction tube that connects to the device to a polyurethane film that is covering foam that is creating a closed and moist environment for wound healing. Utilizing negative pressure wound therapy can be prophylactic straight after surgery and can also help with already infected implant. The salvaging of these infected implants can have as high success rates as 80% with the utilization of negative pressure wound therapy, and time to final reconstruction can be reduced from 220 to only 70 days. As we can see on this graph, It is analyzing the costs of negative pressure wound therapy compared to standard dressing. And although in the beginning the utilization of this wound therapy can be quite costly, as we progress with the patient's healing, the reduced amount of clinic and outpatient visits can actually be cost beneficial to the practicing clinician and to the hospitals. Our aim is to find the most effective technique to minimize complication in implant-based breast reconstructions. Our clinical question is, can the use of negative pressure wound therapy help achieve lower infection and better salvage rates in implant reconstructions? Our PICO consists of a population of patients undergoing implant reconstruction. We're comparing negative pressure wound therapy to standard care, and we're looking at postoperative complications such as infection, seroma, hematoma, and we're also looking at the success rate of salvages. We hypothesize that the use of negative pressure wound therapy in breast reconstruction can help achieve accelerated wound healing at a better salvage success rate. The clinical implication is implementing the use of negative pressure wound therapy in hopes of an accelerated wound healing and less complications. Our key articles all consist of similar outcomes, surgical outcomes, and all have a follow-up of at least 1 year. We have conducted a preliminary search in 3 databases, with the search key consisting of 2 domains, the first domain being breast reconstruction and the second one being negative pressure wound therapy. In summary, we have been working on 2 projects in the last 3 months. The first one focusing on the use of adjunctive materials to help irradiated patients, and the second one we are investigating whether it is useful to implement negative pressure wound therapy in prosthetic breast reconstruction. We are planning to submit these articles during 2025. I would like to end my presentation with a quote, "Live as if you were to die tomorrow and learn as if you were to live forever," by Mahatma Gandhi. Thank you for your kind attention.
Thank you very much for your excellent presentation. And I would like to ask the audience, please, question here.
Thank you for the presentation. It was great. I have a question about the negative pressure wound therapy. Are there any groups of patients which this kind of treatment would be contraindicated?
Well, generally negative pressure wound therapy, since it causes suction. For example, patients who are experiencing a lot of postoperative pain, higher than normal, it is contraindicated since suction creates more pain, and also patients with coagulopathy, so who are more prone to bleeding since it improves vascularization, and also who are maybe allergic to these materials like the polyurethane film or the foam used in negative pressure wound therapy.
Thank you.
Do you know the average length of the negative pressure wound therapy treatments? I mean, how many days or weeks actually?
Well, I'm not exactly sure since I'm not a practicing clinician yet, but I think it's like around a week, for example.
Okay, thank you.
What is your opinion? Should we use for all patients this negative pressure wound therapy, or only for selected patients with adverse events only?
Well, the studies imply that since it is quite costly, that we should apply them in high-risk patients, such as patients with a high BMI, who are smokers, who have diabetes, or so generally patients that are prone to worse wound healing, that actually need this extra help in the healing process.
Thank you for your answer.
I'm just wondering, because I'm a little bit also there the breast plastic surgery. What do you know, or has any data? How widespread this technique in our country? Do you know?
The first topic?
Yeah, no, the second negative wound.
Well, it is not negative pressure wound therapy in general surgical practice, as far as I know, is upon request. So it's not everyday practice, since our healthcare system is, as we all know, with higher cost therapies, we have to request it in advance. So it's not part of everyday practice. It is only used in more complicated surgeries.
Thank you. So you mentioned that it increases the pain, this negative wound pressure therapy. How is the compliance of patients adhering to this therapy?
Well, since they generally don't take the negative pressure wound therapy device home and they stay in the hospital until it is on them, generally they comply, I would say, quite well, since they're not leaving the hospital. So
it's not a question, it's a comment. So there are devices which the patient can go home, so some kind of mobile devices, and this is the everyday practice. So for example, at our department we use it every day. So but in wound infections, in the surgical site infections, but it is everyday practice, and it is has a different finance today.
okay. Well, thank you for that.